Good morning, everyone. Welcome to the Grand Rounds season finale. My name is Alex Harris, and I'm one of the Grand Rounds co-directors, along with Drs. Adi Talati and Rebecca Muley. We'll be off on a summer hiatus during the month of August, and we'll restart Grand Rounds on September 3rd with Dr. Ofer Yitzhar. Today's Grand Rounds is a special lecture in honor of Dr. June Jackson Christmas. Before we introduce the speaker, a reminder that if you're participating via Zoom, please post questions using the Q&A feature, not the chat. I'm joined online today by Dr. Rebecca Muley, who will forward questions to me for our speaker to address. We encourage trainees to consider asking a question, and we'll hold space for trainee questions in person and online. Please indicate in the Q&A if you're a trainee. Please also remember to fill out your CMA surveys after the talk if you would like CMA credit. There's a QR code on the table outside for those in person, and the link will be posted in the chat on Zoom at 12:15. To introduce today's speaker and the June Jackson Christmas Program and Grand Round Series, I would like to invite Dr. Patrice Malone, Associate Professor in the Department and Associate Program Director of the Residency, to the podium.
Good morning, everyone. So nice to see you this morning. I just want to take a few minutes, don't want to take too much time from the speaker, and yet do want to acknowledge that this is the 10th summer of the Dr. June Jackson Christmas Program. Thank you. So I started the program in 2016 with the clinical fellowship, with the idea that we really do want to be encouraging medical students from a variety of different backgrounds and life experiences to consider becoming psychiatrists. In 2017, we expanded the program to include the research fellowship. And then in 2021, as a faculty member myself, I started working with residents, and they wanted to expand the JJC program. And so Nicole Tuchilum was a resident at the time. And in 2021, she expanded the program to include a senior medical student elective. She has stayed on as faculty here at Columbia. Jade Avery led the program subsequent to her, and then more recently, Chiameka Ezie. And this year, Matt and Tayo, two PGY3s, will be leading the program. In this year, in 2025, Tofumi Oshodi, who actually was a JJC fellow herself and a resident here, started the college enrichment program. It is a semester program where essentially New York City college students come here to Columbia, experience our outpatient psychiatry, one of our outpatient psychiatry clinics, and also the CPEP. They get some enrichment in for taking the MCAT, and we really are exposing them to mental health professions a little bit earlier on than medical school. Two of those students have now gotten into medical school, which is really exciting. So Monica, who is a PGY3 and also a prior JJC fellow, is now going to lead the college enrichment program this year. So just to give you some updates on the JJC fellows, we've had over 80 participants in the program. 76% of those have chosen to become psychiatrists. I think I would call that a win. And now that the program is 10 years old, some of those students have graduated from medical school, gone on to residency, finished residency, gone into CAP fellowship, addiction psychiatry fellowship, including here, public psychiatry fellowship, become assistant professors in academic institutions, have set up private practices in communities of color, and are engaging in community psychiatry. I just want to quickly give thanks to those of you who have participated in this program or supported the program in some way. This is really our program. It is a departmental initiative, and we could not do it without the clinical services, the research PIs that sponsor the students, our lecturers, grand round speakers, mentors, the funding that we have received in the past, including from the APA SAMHSA Minority Fellowship, which is how I started the program in 2016, funding that we have now from the Rudin Foundation, in the past from Leon Levy Foundation, from NIMH. And then I, of course, want to thank my mentors who have sponsored me and championed me and this program over the years, Alyssa Arbuckle, Stephanie Lamel, and Lou Baptista. So congratulations to us on 10 years. So I'm going to welcome Monica up to the stage, who is going to introduce our Grand Round speaker.
Happy Wednesday, everybody. Again, my name is Monica Perdomo. I'm a third-year psychiatry resident and an alumni of the Dr. June Jackson Christmas fourth-year elective. I want to take this time to extend my gratitude to Dr. Malone and everybody who has helped with the expansion of the JJC program. The program is honestly the reason why I'm able to stand on this stage today and present our next speaker. It is my honor to introduce Dr. Oscar Jiménez-Solomon. Dr. Oscar Jiménez-Solomon holds a PhD in social policy from the Columbia University School of Social Work, a Master of Public Health from the Mailman School of Public Health at Columbia University, and a bachelor's in sociology from the Pontifical Catholic University of Peru. Since 2013, Dr. Jiménez-Solomon has served as a research scientist at the New York State Psychiatric Institute, Columbia University Medical Center. In 2022, he joined the NISP Mental Wellness Equity Center, leading the development of a community-based intervention targeting financial hardship as a social determinant of mental health. Additionally, his work at the Columbia Center on Poverty and Social Policy focuses on improving the measurement of socioeconomic stressors in mental health epidemiology and understanding the longitudinal relationships between income, material hardship, and psychological distress. In 2024, he was appointed Assistant Director of the New York State Center of Excellence for Cultural Competence. There, he leads a study to develop and evaluate a peer-led financial empowerment intervention aimed at reducing financial hardship and suicide risk. He has served on advisory boards and committees for organizations such as the National Disability Institute, Academy of Peer Services, American Psychopathological Association, and the World Association of Cultural Psychiatry. He is a frequent keynote speaker at both national and international conferences on mental health equity and social determinants of health. Without further ado, please help me in welcoming Dr. Oscar Jiménez-Solomon.
Good morning. I'm not sure if I have much more to say after that. But thank you so much. Good morning. And I would like to begin by expressing my deepest gratitude to give today for the invitation to give today's grand rounds, especially in the context of the June Jackson Christmas Fellowship. It's quite an honor, especially because although I didn't get to meet Dr. Christmas, I understand and I know her as someone who was a pioneer in psychiatry, a strong and bold public health leader, and also through her roles as New York City Commissioner of Mental Health in the 70s and other leadership roles as quite a disruptor of traditional mental health services. She understood really well the deep connections between mental health, racism, and social structure. And her work, especially today, reminds us that mental health is not just or only a clinical issue, but also a social and a political one. Quite profoundly embedded in environments, context, policies, and also the histories of exclusion that many communities experience. This seems especially important today at a time when racism in America seems to have acquired new and profound ways, and public and political systems are actively undermining the gains of equity-focused efforts since the civil rights movement more than 60 years ago. So it feels especially meaningful to me today to talk to you about the social and economic determinants of mental health and how we can move forward to not only for our clients, patients, participants, but also collectively as a society and mental health communities towards a more equitable mental health system, social structures, and through specifically interventions, meaningful interventions, policies, and partnerships between mental health and other sectors of society. Neither I nor the planners have any financial relationships to disclose. My hope is that by the end of today's presentation, we will agree on a few things. That in understanding and addressing social determinants of mental health, and specifically economic determinants, by directional relationships matter, and that the type of economic indicators that we study and address also matter. That ethno-racial disparities in social determinants of mental health matter, as well as the social policies that we advocate to redress the economic inequities that drive ill mental health. And then finally, for those of us that are more in tune with practice and individual level work, that individual and community level interventions to address economic determinants of mental health also matter and are in fact possible. So I'd like to start by sharing this picture. Picasso painted this more than 120 years, almost 120 years ago. And we don't really know exactly what he meant, but what many of us can see is that the student, the head of the medical student, has one eye that seems to be shut and one open, and maybe one ear perked up. Like in many specialties, medical training, and I think myself as a social scientist, I can say the same thing. We are asked to specialize, right? To actually hone in our attention on one or few dimensions of the human experience. But in doing so, we may miss the whole picture. And I show this picture to remind us that examining and understanding the economic determinants of mental health might actually require a new paradigm in psychiatry, one that integrates a clinical lens with also a social and structural lens. So I'm going to center this talk specifically around economic determinants, like our title indicated. And so to contextualize that, I want to just underscore that the field of social determinants of mental health is much more vast. This is one depiction of it based on a review that Craig Lund and colleagues conducted several years ago, widely adopted by the World Health Organization in connection to the Sustainable Development Goals, where economic determinants are one important dimension, but certainly not all dimensions of social determinants. I will focus today on a set of economic determinants, their role, what we know in their research, and potential strategies and interventions that we may be able to adopt to actually address these. So, by relationship directions matter in social determinants. Typically, when we hear the term social determinants of mental health, I think most of us probably hear one direction of the relationship, right? How social and economic factors affect mental health. But the reality is that the research points towards bidirectional relationships at the core of the impact that social determinants have. Matthew Ridley, Bikram Patel, and others, and other colleagues conducted this review, focused specifically on the evidence around mood and anxiety disorders and the relationship with poverty. And what they find is that poverty is associated prospectively with exposure to stress, poor health, and social comparisons, among other mechanisms that in turn increase the risk for the development of mood and anxiety disorders. And that in turn, these actually show up for many people in decreased productivity, being able to work less, receiving less income, and also experiencing impairments and limitations in development that affect further their economic integration. So this is not a new theory. I'm going to present another angle of it and just a few other more specific mechanisms that we know through our research on the relationship between socioeconomic status and mental health. That the first is what I'm going to refer to in this talk as the social causation theory or the social causation effects. And what we refer by that are the effects of either low socioeconomic status or economic determinants on mental health, typically through mechanisms like the experience of financial strain. The more common term these days is material hardship, People with low socioeconomic status are also likely to experience more levels of indebtedness, which in turn can lead in the research to increased risk for suicide and depression and entrapment, financial stress, which can actually increase the risk for anxiety, social comparison, which can lead to shaming experiences and in turn also to increase risk for suicidality and also mood and anxiety disorders. But the flip side of that is what we call the social drift theory. In this talk, I'm going to refer to social drift effects. And what I mean by that are the effects that decline in mental health have in turn on economic determinants. And we know, for example, that when people experience mental health distress and untreated mental health disorders, their ability to produce, stay engaged in work the same amount of hours, et cetera, decreases, especially when they don't experience the protections of savings, assets, or the benefits to be able to take time off, for example. Increased health expenditures that also, in turn, can actually lower someone's socioeconomic status and also geographic drift. As people decline in health conditions, sometimes they also experience a geographic drift that lead them to moving into neighborhoods or communities with lower resources. These are just some of the mechanisms and some of the relationships that we want to highlight to contextualize some of the research that I wanted to share today. So what I'd like to share today is findings from a study. Some of these are actually published results and some unpublished, from an overall project where we have sought to better understand the longitudinal relationships between economic factors such as individual earnings, family income, and experiences of material hardship, and psychological distress. So this is a simplified model of what you're interested in, the statistics of it. That's a simplified model. Roberto's smiling over here. It doesn't depict, for those of you who are interested, the latent variables that control for the fixed effects. Basically, what you're seeing here is an attempt in the models that we use in this study to examine what we call the cross-lag relationships between economic determinants and mental health and how these might affect each other over time. This is actually based on a study of New York City working age adults. A representative sample is part of a study conducted by the Center on Poverty and Social Policy, the Poverty Tracker, that has had several panels over the course of the last 10 years. I use here the findings from one of the initial panels between 2015 and 2019, right before the pandemic. And we have about 3,100 individuals in the sample. So in sum, on this question of what social causation and what social drift effects do we find? In the upper section of the figure, you actually see the summary findings for the relationship between earnings and distress, and in the lower, the relationships between family income and distress. Well, we have a few takeaways. The first is that in the relationship between individual earnings and distress, we see what seems to be a bidirectional relationship where both social causation and social drift effects take place for the overall sample of New York City working age adults. In some, as for example, individual earnings decline over the past year, we actually see changes and increases in the level of psychological distress measured by the K6 or the Kessler-6 measure. In turn, as this decline, psychological distress increases, mental health declines. A year later, we actually see a statistically significant change in the level of individual earnings in the direction that we would expect. What we see, though, is that for the general population in the lower section of the figure, this relationship between family income and distress, we only see a significant effect on the social causation side, meaning that declines in the level of psychological distress don't translate into a significant decline in my family's, as my psychological distress increases or my mental health declines, that doesn't translate into a decline in my family's income a year later. but the picture gets more nuanced. And what I'd like to focus as one of the subgroup analysis that we conducted, just because of the theme of the talk and the objective of highlighting and underscoring the ethno-racial disparities, is how these social causation and social drift effects seem to differ across ethno-racial identities. What we see here first is that in the relationship between earnings and distress, we do not seem to notice any notable differences in the social causation effect of earnings on distress. The effect of for Hispanics is borderline significant, but it's hard to actually compare the magnitudes of these effects. They're relatively similar. What we see, however, is that the social drift effect, meaning I decline in my mental health, my psychological distress increases, shows up in individual earnings a year later, only in a meaningful way for Hispanics in the sample. And we can see that here again, the green circles or ovals are actually depicting the social causation effects, and the red actually the social drift effects. When we look at family income further, what we see is that the most significant pattern emerges for Hispanics as well, where the social causation effect of family income on distress is actually borderline significant for Hispanics. And further, that for Hispanics in the sample in New York City, we actually see a significant and more notable impact of changes in psychological distress in the family income for that individual. So trying to understand what that might mean. We know that Hispanics as other minoritized communities, and actually this includes Black communities in the country, occupational insecurity is actually significant. A few hypotheses that the employment precarity that people experience an insecure and stable and unpredictable employment may actually lead more easily when people experience changes in their mental health to declines in their earnings a year later. Barriers to access in mental health care, lack of the social and economic capital, such as asset savings and the like, to be able to cope with declines in health. And also that the family income for Hispanics might actually depend more heavily on individual earnings as opposed to other forms of income. What's also, and probably the only real unique element here to Hispanics, is the role that immigration exclusions may actually have in increasing the socioeconomic and mental health vulnerability of individuals. So, however, with that exception, these factors would not explain the differences between Hispanics and Blacks, which actually requires further research. All right. So moving on to another aspect of the bidirectional relationships, just want to highlight here one of the other elements of this study has been to try to understand not only the relationship between income, two forms of income and distress, but also this third variable, which we call material hardship, which refers specifically to the extent to which people are able to meet basic needs such as housing, food, and also be able to meet basic bills such as rent, utilities, and other core services. So what I'm going to present briefly are the longitudinal relationships through parallel growth process models between income, experiences of hardship, and psychological distress. So I'm going to skip this or mention it very briefly that before we proceed, one of the challenges in measurement and social determinants, especially with complex factors, is that the measurement of these sometimes is not straightforward and requires a lot of studies. So one of the key questions is the longitudinal invariance or stability of our measures, right? So briefly here, what you see is that we actually examined for material hardship, the stability of 1 and 2 factor models. And what we see at the bottom right, actually, in essence, is the comparison between a model that constrains the loadings on the structure of the factors and also one that releases them. And what we see is actually that comparison actually is non-significant, which suggests that actually the measures themselves are actually stable over time and actually allow comparability from one time to another. So to sum up, on these parallel changes, parallel growth models. So what we see here is that, in essence, or what I'd like to highlight here is that we find two factors within these indicators of material hardship that we examined. One, the groups around just what may be more severe experiences of hardship, the inability to meet basic needs, such as ending up homeless, having to move in with other people, lacking food, running out of food, and not being able to meet basic medical care. That's actually what goes under this construct of unmet needs. The second one is this bill paying difficulties, such as the experiencing inability to pay for rent, inability to pay for basic utilities like phone, electricity, and the like. What we see here is that when we separate these two constructs, we notice that the effect of changes of unmet needs are associated with changes over time in the levels of psychological distress, which is actually what you see here in this 0.6. These are standardized effects where one standard deviation change and this dimension of material hardship, the inability to meet basic needs, translates into a 0.6 standard deviation change in psychological distress. And we also actually see here is that this earnings has an indirect effect on psychological distress, as we would expect from our prior analysis, but that this a proportion of this effect, actually more than half of this effect, is mediated through the experience of material hardship. I'm going to jump here to our next look, which is actually, these are, again, these cross-like panel models, where now we're trying to examine not the relationship between changes for the entire groups, but these are actually within person changes, meaning the effects that you see here are how changes for one individual are associated with changes for that individual later. It's a bit of an oversimplification, but actually it's based on unit fixed effects. So here, what do we see? That, as we would expect, we see both social causation and social drift effects for material hardship. What is actually important to notice here is that if you remember the effect of earnings and income and family income on distress, the relative to the effect of material hardship, we see a stronger effect of changes in material hardship over the past year on psychological distress, on current psychological distress, which might actually suggest that material hardship, the experience of strain, is actually closer in the causal pathway in the relationship between economic factors and psychological distress. This is not a new idea. Early 1980s, sociologist Leonard Perlin and others developed this stress process theory, and with the structural equation modeling that they had available in 1981, they actually conducted this analysis. In essence, find very similar patterns where job disruptions translate into experiences of economic strain, in a decline in psychological resources, which in turn, over time, in a longitudinal study in the U.S., led to changes in the risk for depression. What is actually perhaps new in the contribution of this study that I'm presenting is the reliance on individual level, unit fixed effects, individual level changes as opposed to group changes, and also incorporating the not only social causation but also their social drift dynamics. I'm going to actually jump to this slide here, which is our attempt to tease out the extent to which this impact of different dimensions of material hardship, unmet needs, and the ability to pay for bills might actually differ across ethno-racial identities. So in sum, we see what seem to be different patterns, and not simply in the direction that we would expect. We see that the social causation effect of unmet needs is notable and significant for Hispanics and whites in the sample, and not for Blacks in the sample. But that for Blacks in actually our sample, the effect of hardship around the ability to pay for bills had a significant impact on distress. On the flip side, we also see that the social drift effect of psychological distress on unmet needs is actually significant for both Hispanics again and Black and whites, and not for Blacks in our sample. Try to draw some conclusions towards the end, but I'll leave you with those thoughts for now. So the question that you're probably wondering, and I promised in the talk, is what can we do about it, right? What kinds of interventions, social policies, and interventions at the individual and community levels may work and may be possible. All right, so this is not my field, but to contextualize, I'm going to focus on a few examples related to the understanding of the mechanisms around suicidality, which is one of the areas that I work on, and especially around this experience of financial problems and how they their experience subjectively. This is actually a depiction of the stress diathesis model that integrates and hypothesis mechanisms from contextual factors to the experience of distress and epigenetic and physiological changes that might actually increase the vulnerability to experience and external stressors with heightened distress. So this is quite an oversimplification of the literature that we are aware of, but I just want to highlight a few things, and especially focusing on what seem to be subjective mechanisms that might link the experience of objective financial hardships and declines in mental health and also suicidality. Some of the most cited and most studied mechanisms seem to be the experience of stress, the experience that my finances are something that I worry about, that I'm uncertain about, the experience of threat, which is also a specific scale that has been developed and studied. The financial threat, meaning experience of uncertainty, risk, something bad's going to happen as a result of my financial conditions. Shame, almost a universal experience of poverty and financial difficulties, especially in societies in which we experience personal difficulties as a reflection of personal failure, which is actually a societal value that we seem to reinforce in many different ways. And also the experience of entrapment, that there's no way out of these financial difficulties, which can actually not only increase hopelessness, but also risk for suicide. So a couple of examples. This is not my research, but it's one of the hypotheses is that economic hardship, the financial threat mediates the relationship between experiences of economic hardship and suicidal ideation. In our own work, we find also, actually, colleagues here, Brian Primrose and Roberto Luis Fernandez from the Center for Cultural Competence, who participated in this research, where we actually observe also what seems to be the mediating role of the subjective experience of financial hardship, including measures of dissatisfaction and shame about one's financial situation, mediating the effect of the association between financial hardships and also psychological well-being, like hope and life satisfaction. So, honing in more on interventions. One of the things that we see is that generally in the field of mental health, economic determinants have not been addressed sufficiently, specifically around suicide. 8 years ago or so, one of the most comprehensive reviews of the literature, longitudinal studies examining the risk factors for suicidal ideation attempts and death, found that low socioeconomic status had statistically almost the same level of association as prior suicide attempts and suicidal ideation, contrary to some of the understanding that we've had that actually prior attempt and prior suicidal ideation are the best predictors. Consolidating the evidence, they actually find that also low socioeconomic status has relatively similar statistical impact on the risk for death by suicide. The question is, why are we not being able to do more about it? The CDC and national guidances, this is actually 2017, 2022 Resource for Action. These are actually guidance documents from the federal government to the states. Have actually called in the attention to strengthening economic supports as actually one of their primary strategies, and yet not translated yet into state suicide prevention plans and other mental health policy development. So I'd like to turn in that context now to some of the evidence of this broader social policies at the more macro level that might actually have an impact on improving mental health. This is actually, this is in part based on systematic literature reviews of the last few years, and also our own interpretation and review. In our opinion, the strongest evidence of the social policies that seem to have an impact on mental health outcomes are cash transfers. We have other experts here in the room that could probably talk more about it. Specifically in the United States, the Earned Income Tax Credit, which is actually, in reality, the largest cash transfer program that we have in the United States. I'll comment a few things on it. Minimum wage, changes in minimum wage translate into improvements in mental health. Increased participation in SNAP or nutrition supports, and also increased unemployment benefits, especially during times of recession. They have all been associated with improvements in mental health and also declines in suicide rates specifically. A few other policies that are under study, the child tax credit, housing insecurity policies, financial counseling, and other more localized interventions. So first, on cash transfers, this is actually a whole talk can actually be dedicated to this. I'm just going to share this one summary. This is actually from a systematic literature review in which conducted specifically in low and middle income countries, but very similar patterns can actually be seen in high income countries. The long and short of it is that consolidating the evidence of randomized controlled trials in multiple countries, what we see is that that cash transfers on the whole have a about 0.11 standard deviation impact on mental health improvements, meaning that a 0.1 improvement in the income associated with the cash transfer that an individual receives is translated into for a 1 standard deviation in change in their income as a result of the cash transfer. This translates into a 0.11 improvement in subjective and mental health overall. We see too here that the impact on subjective well-being is actually seems to be stronger than the impact on mental health, and that could require that we could get under the hood quite a bit under this, but just to give you an idea of some of the evidence that we know internationally about the impact of cash transfers. In the United States, we have some more local evidence about the impact of one of the cool things about the Earned Income Tax Credit and other social policies is that they're natural experiments. Each state can actually enact different levels of EITC, which are actually refundable tax credits given to low income and middle income families that work. And that variation and over time allows us to actually study the policy impact on changes in mental health at the global level, state or country. So in sum, one of the things that we see here from the research is that there was a big increase in 1990 in the ITC, and actually that translated into improvements in depression, especially among low-educated women, and that a 10% increase in the ITC, this is based on state-level changes, translated into fewer poor mental health days, which is a measure used in national surveys, a reduction in suicide, non-drug suicides, and also suicide attempts at about a 3%, by a magnitude of 3% in the decline of suicide rates. The child tax credit has more emergent research. We conducted ourselves some study a few years ago when during the pandemic, there was actually a significant increase in the child tax credit and the benefit that families received for having children. It was actually a natural experiment that, in fact, there was a change at the federal level in the amount of money that families received because they had a child. And what we see through this research is a little bit more mixed. We found in one study that the short-term impact, this is actually only 3 months into the process, didn't seem to have a significant impact on depression and anxiety. But later research has found that those increases translated into improvements in mild psychological distress, especially among Hispanics, and also further research on declines in depression and anxiety, especially among Blacks and Hispanics, which is actually a common theme about the impact of some of these cash transfers, that they often tend to benefit those with low education and fewer resources, like interracial and minoritized individuals. The evidence of minimum wage is actually strong too. What we see here, one of the most notable studies of the last few years, is that also leveraging the changes in the rates of minimum wage across states and over time, we can actually estimate their impact on different outcomes, including suicide rates. I'm only going to comment one, the first bullet, which is that a 10% increase in minimum wage has been associated with a reduction in non-drug suicides by about 3% among those with low education, high school or less, which is the population that we would expect to be most likely to be benefited by this kind of policies. Other social programs that are worth mentioning that I want to review the evidence are actually housing eviction moratoria policies during the pandemic. There were some programs that actually prevented people from being evicted. SNAP as a federally funded support to low-income families in the area of food and nutrition, also associated itself with declines in increased participation associated with declines in suicide rates, unemployment benefits, especially in the context of recessions, and also sick leave, which, as we would expect, when people get sick, they're actually able to maintain their income and be able to cope with physical and mental health declines. So, moving on to our next domain, which is that not only social policies matter, but also that interventions at the individual and community levels do matter as well. So I wanted to share briefly about an experience where we've actually, several of us, including our colleague Francesca Riley from the Center for Cultural Competence and other colleagues from OMH, Meryl Rotter, Marlene Radigan, and Miriam Tepper, worked over the last year to develop a platform where we've actually sought to integrate indicators of social determinants with behavioral health indicators in a way that can actually help us leverage existing data to help better inform policy development and also identify geographic areas that might actually have the highest mental health and social needs. So this platform integrates behavioral health indicators such as the frequent mental distress, which is actually a measure used by the Behavioral Risk Factor Survey. It's a rough measure based on the number of poor mental health days, and the cutoff of 14 or more indicates frequent mental distress. Social determinants, the most notable here is an index that was developed to better capture the social vulnerability to natural disasters, the Social Vulnerability Index, SVI, and a few other specific measures of poverty, unemployment, housing, food, and other social contexts like homicide. This SVI index integrates all those measures. If you're interested in the way that these concepts are developed, I have some references. I'll be happy to talk to you about that. I just mainly want to highlight one example of the utility at the community and state level of this county and state level of this kind of tool that is that can be developed with existing data. What you see here on the upper left hand is a map of New York State. And that map actually highlights, it shades in from white to dark blue, the proportion of residents who are estimated to have frequent mental distress. The lightest color is the lowest quartile, and the darkest color is the highest quartile, quartiles 1, 2, 3, and 4. The one on the right, the upper right, is a map of Albany County, and I'll get there. So what you see here, when you look at the map of New York State, is that Albany County, which is right in the middle there, actually can be categorized in the lowest quartile of frequent mental distress. Nothing to worry about. We should prioritize other areas. But when we look within the county, we actually see that the story gets more complicated, where we see areas with in the third and the fourth quartile, this concentrated area with the darkest blue fourth quartile level of frequent mental distress is actually the city of Albany. And we can actually get further honed into the census tracts within that county, which is actually the maps at the bottom here. What we see here on the left is actually the map of frequent mental distress for the city of Albany divided by census tracts. And what we see here is that there's a concentrated, for those of you who are familiar with the city, it happens to be the downtown area of Albany, which actually just notably has lower income and lower resources, and the outskirts that tend to be more suburban. Using that example, we see that when we look at two concrete tracks, track 006 and 013, they have very different profiles. The first thing is that we see here on the right-hand side, the lower corner of the figure, that here is a map of the prevalence of the social vulnerability index by quartiles. So we see here that just visually, there is a significant level of overlap between these two indicators, as we would expect. The social vulnerability and mental health distress overlap, and that there are a number of census tracts that are likely to have both social and behavioral health needs together. What we don't show you here is that when you look under the hood a bit, you see that, as expected, the one census tract 006 with the lowest actually has a 12% level of frequent mental distress, which is about 2/3 of the state average, relative to 13, which is actually a frequent mental distress of 24, meaning 24% of the population report frequent mental distress on this tract. We also see significant differences in the patterns of poverty and also ethno-racial composition. Just to give you one sense, Albany County Tract 006 has about 90% of white individuals and communities, and 13 about 80% of Black African-American identified individuals. When I share with you another example of another community level effort that is underway, this is actually led by a couple of colleagues in Chile, Dr. Pablo Mendez and Dr. Christian Cortez, who have been implementing an ecological momentary assessment using a digital platform in the Maule region in Chile to assess the innovation is not only mental health risk and severity, but also financial hardship. In some, they've integrated 3 indicators of financial hardship, which we are studying in other projects as potential screeners for financial hardship, and also examine batteries of indicators of depression using the PHQ-8 and also the CSSRS and the GAD-4 to better understand the relationship between these factors. As we would expect, we see here that financial hardship has an effect, is associated with suicidality, increased suicidal ideation, and that most of this effect is actually mediated by its association with depression. The next phases of this project are to conduct follow-up assessments with the sample of 5,100 college students in Chile, and to be able to develop features through this digital platform to push notifications and referrals to those that have the highest both social, economic, and mental health needs. Also want to share about another study that there's growing evidence around, which is financial counseling. I'm going to jump to this here and then go back. So something that many people don't know, perhaps some of us in the room, is that the city of New York, like many other cities in the country, have free, publicly funded financial counseling programs. Any resident or worker in New York City can actually access them. Many of us could benefit from it, and certainly people with mental health distress and other mental health conditions who are also experiencing financial difficulties. What we know so far is that RCTs and other evaluations of financial counseling see a reduction in financial stress, subjective financial stress, anxiety, and also improvements in self-efficacy, which actually signal a potential benefit effect on mental health, in addition to the potential effect economically by receiving financial counseling. I just want to put a plug in for one service that I'll link back when I mentioned some potential strategies that clinicians and mental health practice we could embrace, is that also New York City, like every other town and city in the country, has free tax preparation assistance programs, VITAs, voluntary income tax assistance programs. And these are actually places where people can go, low income, moderately income, to receive free tax preparation assistance, and that way avoid the fees that come associated with the taxing, and also be able to actually check and double check their eligibility for the earned income tax credit. The child tax credit could actually bring back thousands of dollars to their pockets and hence serve as a cash transfer for that. I want to comment briefly about the work of another colleague at our center, Shima Sadagiani and others, on the profiling or the latent classes that we can find around financial inclusion. So in essence, what this is a profile, a latent class analysis based on 13 indicators that combine or integrate, represent access and utilization of formal financial services such as banking, debit cards, credit cards, and the like, and also informal or alternative financial services like pawn shops and payday loans and the like. And what we see here is two things. One is that we see a combination of patterns. As expected, there is a class, which is actually the blue line, that seems to be mostly integrated in formal financial services with very low use of informal financial services. But there's a class in the middle, which is relatively small, but actually notable, that relies heavily on alternative financial services like pawn shops, payday loans, and the like. And there is one third class, which is the green dotted line, that in general is excluded financially from all kinds of services. This is actually based on a sample of 215 individuals with psychiatric diagnosis in New York State. The one plugin I want to put in around how this seems to also be associated with racial disparities is that what we see here, the main finding I'd like to highlight is that those self-identified as Black have the odds of those who are actually self-identified as Black, their odds of belonging to the most excluded class, 3 class, is actually 3, which is actually in pattern or in conjunction with other research that we find in the general population, meaning that among people with mental illness, individuals who are Black, controlling for a few other social demographics, are 3 times more likely to actually be completely excluded from both financial services, informal and formal. So I have 5 more minutes, and I just want to comment very briefly on a couple of interventions that are under development. From Hardship to Hope is one intervention that we're developing and testing with the support of the American Foundation for Suicide Prevention. In essence, this actually builds on some work that we've done to operationalize the concept of financial wellness and the concept of hope. And this is something in testing, which is the notion that, for those of you who are familiar with Snyder's hope theory, we can actually find a parallel where the 3 components of hope in Snyder's hope theory are that what creates hopeful thoughts is the awareness of goals, a sense of agency that I can actually achieve those goals, and the pathways to achieve those goals. Something similar could be said about financial wellness goals. So where we see the importance of accessing the pathways, the financial wellness supports, to be able to help me achieve my financial wellness goals, and also the importance of empowerment, skills, understanding, and also the beliefs to actually help me activate those pathways. There is curricula that we have developed over the years on financial wellness. I'll leave you this here in case you're interested. And in essence, this is the logic framework that we're working with. We're actually hopefully over the next few months move on to our next pilot, which is a pilot to test this intervention. It was actually tested in a developmental pilot where we combine group sessions with individual sessions led by peer specialists who've been trained to deliver this intervention, with the hope that this will actually have an impact not only on their objective experiences of financial hardship, but also their subjective experiences, which from the prior research, we actually believe that can be affected through more immediate interventions, perhaps more easily and more quickly, that changes in objective financial hardship, and that actually may be an important area for psychosocial interventions. Another intervention that I want to mention very briefly is also one conducted by the Community Wellness Center here at Columbia Psychiatry, Engage. This intervention is being delivered in New York City with funding from the state of New York. It utilizes a brief screening tool on mental health, the mental wellness tool that contains 3 screening items and 10 follow-up items, and also a financial wellness tool that is currently in testing, where we actually test 12 items, we're utilizing 12 items to examine financial hardship, and based on that, provide different kinds of supports to those that are eligible. This is actually a little bit of the scheme of this financial wellness tool in testing, which actually touches on areas like food, housing, utilities, medical, and indebtedness, which are key areas in the research. And in general, so far, we have an initial sample of 308 individuals. What we see here, we are seeing here are the percentiles. We see that at least 20% of individuals have one or more financial hardships. And in some, what we take from here, and I'm actually rushing here to just get to the end, is the widespread need and prevalence of financial hardship indicators across this population. And also what we see, although many of them are actually approaching our intervention because of their mental health need, they're screened for financial hardship and offer a financial wellness intervention, which is actually follows more or less this process. And we see that over 50% actually want to engage in the intervention, although it wasn't their initial thought, and that may actually be more motivated to participate in the mental health interventions such as interpersonal counseling and the like. So I want to end by just briefly mentioning a few strategies that we may be able to implement in mental health care settings. First is to screen. There are several screening tools that have been developed, some of them validated with different levels of validation. The CMS social needs tool is one of them that is being implemented in a lot of systems. The first thing we can do is identify the need. The second one is to engage clients, participants, patients in conversations, meaningful conversations about really what's most troubling to them and how this actually connects to what the things that really matter to them in their lives, which is most likely where the heartbreak and the pain is coming from, right? That it's not only that I cannot pay my debts, but that I may not be able to help my kids get to college, and I may be able to help send money to my mother back in Peru, or whatever else is actually meaningful to the individual. The third is to actually support people to plan, to develop concrete goals and action steps, to link individuals to existing resources like the financial counseling, free financial counseling, case management if that's available, and other supports. And then the fourth or the fifth is actually to provide ongoing support, not only with the concrete economic stressors, but also with the emotional impact that this have. They are recently very interested. This talk has now been informed by this. There's a recent review by a few colleagues, including Dr. Luis Fernandez here and Ron Kessler, that actually review some of the evidence on social determinants and provide some specific recommendations to clinical practice. To conclude, so I'd like to say again that bidirectional relationships matter, that we see that a more dynamic and cumulative disadvantage perspective or view of the social determinants is perhaps more accurate. One in which we recognize the role of social causation effects, social drift effects. One also in which we pay attention to the kinds of economic indicators that we study and that we address. because depending on the kinds of indicators that we focus on, we see different relationships, and it's hard to make blanket conclusions about the role of economic determinants on mental health. The timing matters. That there are some SES indicators, like education, for example, that cannot be changed easily, and that may have long and enduring effects. But that there are other indicators, such as changes in income, changes in levels of material hardship, that we may be able to collectively affect more easily, and that do translate into meaningful changes in mental health. And finally, I want to say also that disparities matter, that it's important to conduct subgroup analysis to better understand these disparities. The subjective experience matters. That experiences of worry, threat, shame, and not only the specific, concrete, objective stressors matter. And then finally, that social policies like the ITC, child tax credit, minimum wage, and others can make a difference to address some of those economic inequities. And that perhaps we should look at them not only as social policies, but also as part of mental health policy. And then finally, for those of us who work in the more individual and community level, that individual and community interventions do matter, are possible, and that are the number of strategies and resources that we can implement. I'll stop here. And again, thank you so much for the invitation. A pleasure to speak to you today.